Hello, I'm Dr. Larry Eichenfield, Chief of Pediatric and Adolescent Dermatology at Rady Children's Hospital in San Diego, and Professor of Dermatology and Pediatrics at the University of California, San Diego. I'll be discussing the paper, 2 phase 3 trials of dupilumab versus placebo in atopic dermatitis by Dr. Eric Simpson and colleagues. This study appeared in the December 15th, 2016 issue of the New England Journal of Medicine. Summary of this paper. This paper presents the results of 2 identically designed phase 3 studies showing that dupilumab improves the signs and symptoms of moderate severe atopic dermatitis, including pruritus, symptoms of anxiety and depression, and quality of life as compared to placebo. This is a very important study. These results confirm and extend findings on dupilumab from earlier studies involving patients with moderate severe atopic dermatitis who had an inadequate response to topical therapy. Now let's drill down into the methodology of the studies and look at the key findings. So this study reported 2 independent, randomized, double-blind, placebo-controlled parallel group studies of identical design involving 1,379 adults with moderate severe atopic dermatitis. Patients were randomized by disease severity and geographic region, and they were randomized on a 1:1:1 ratio to receive either dupilumab 300 milligrams weekly, dupilumab 300 milligrams every other week, or placebo weekly. Patients treated with dupilumab received a 600 milligram loading dose on day 1. Now, the primary efficacy measure in this study was the percentage of patients who made it to clear or almost clear on the Investigator Global Assessment Score, IGA score, and they had to have at least a 2-grade improvement from baseline. And this was this was on week 16 of therapy. And there were several secondary endpoints we'll discuss, as well as assessment of safety. Now, key findings of this really landmark study. Of the 1,379 randomized patients, 73 dupilumab patients and 86 placebo patients did not complete the study. 18 patients in the dupilumab group and 24 patients in the placebo group withdrew due to adverse events. From an outcome standpoint, the primary endpoint, significantly more dupilumab than placebo-treated patients met the primary endpoint of clear of almost clear or almost clear, and at least a 2-grade improvement in their score. In the Solo 1 study, it was 38% of the patients who received dupilumab every other week, and 37% of those who received dupilumab every week made it to clear, almost clear, and the 2-grade improvement, as compared to only 10% in the vehicle. In Solo 2, 36% who received dupilumab every week made the treatment success. The same 36% actually who made treatment success with the dupilumab each week, and there was 8% of those who received the placebo. Significantly more patients with dupilumab than placebo achieved improvement from baseline in the objective EASI score. So at week 16, there's a much higher rate who made it to EASI 75, at least a 75% improvement on the EASI score with dupilumab as compared to the vehicle. And interestingly, the proportion of patients who made it to EASI 75 was the same, whether they received dupilumab injections on a weekly basis or an every other week basis. Now, looking at pruritus, it was quite interesting. Improvement with pruritus was much greater with dupilumab, and this was seen by week 2, so a very early response in itch. Another interesting part of the study is that they looked at patient-reported measures, patient-reported outcomes, including symptoms of atopic dermatitis. And there was not only the decrease in pruritus, which is obviously patient-reported, but dupilumab had an effect on sleep, minimizing sleep disturbance. It decreased the symptoms of anxiety and depression, and it improved quality of life. Fewer patients on dupilumab received rescue treatment. There were some injection site reactions that were more common with dupilumab. Most were scored as mild to moderate severity. And there were exacerbations of atopic dermatitis in both groups, and that was more, as well as skin infections, but more common in the placebo group. So one of the interesting things is in using this medicine that blocks inflammation in the skin, question of whether you see more infections because it has some impact on the immune system. But actually there were less infections with dupilumab than in the placebo group. So my thoughts and analysis of this paper. So first of all, this is really a landmark paper heralding a world of change in eczema therapy. Never before have we had a prospectively developed selective immunologic agent to target atopic dermatitis. The study really brings home the importance of Th2 cytokines, particularly the cytokines IL-4 and IL-13, both of which are blocked by the IL-4A receptor blocker, which is what dupilumab is working on. It actually blocks the IL-4A receptor and blocks IL-4 and IL-13. And this study really shows the potency of this pathway in manifestations of atopic dermatitis. I think it's remarkable to see the objective scores, the percentage of patients who made it to EASI-75, meaning they were 75% improved, as well as the change in EASI, the clear and almost clear percentage of patients, as well as in the drop in pruritus and other patient outcome measures. There was a drop in depression and anxiety scores in the dupilumab group, which really shows that it's impacting the clinical manifestations of the disease externally, but also some of the tremendous secondary consequences of the disease. It really shows the reversibility of some of the life impact of atopic dermatitis. And the patients in this study had really severe disease. For example, these patients on average had over 50% body surface area. And as I already pointed out, the infection rates look lower with the drug than with the placebo. I think the study really impacts state-of-the-art management, as dupilumab's just approved. It'll be a change in our therapy. We've had no approved systemic therapy in the United States other than prednisone, which is not advised because it has tremendous side effects and toxicities. There are other immunosuppressives, but they're hardly used, both because they're not approved and because there are side effects with and toxicity concerns. So cyclosporin, azathioprine, mycophenolate, and methotrexate have been utilized, but not at a high rate. So dupilumab potentially can be a revolution in care. I think that this study, which is the core study, core phase 3 study to back up the approval of dupilumab, really is going to impact the future state of patient management as well. To start with, I think this becomes the systemic drug of choice for our more severe patients with atopic dermatitis. I think the big issue now is figuring out who are the appropriate patients for this therapy. We do have some unanswered questions. For instance, for how long do we treat? What'll happen if we treat for an extended period of time and then stop? Will there be relapse? We don't think there'll be big relapse, but are there going to be subsets of patients who have sustained remissions or not? Conjunctivitis was seen as a side effect in the study. That's an interesting side effect. It didn't force anyone to come off the study, but I don't think it's certain what the cause is and what we should do from a management standpoint if we see conjunctivitis in patients on dupilumab. The pediatric studies, big question mark. We'll be very excited to consider pediatrics down the line, not ready for prime time now. But one of the questions is, can we mediate the disease over time? Can it be disease modifying potentially to use this agent in early treatment? A big question is, will insurance companies require the use of other systemic agents before approving dupilumab, even though they're unapproved and don't seem to have the efficacy safety ratio of dupilumab? So these are important questions, but basically this paper sort of harkens this transition to a new age of eczema care, and one that I think is really quite exciting, can really change the lives of our more severe eczema patients.